Greetings. In this session, we will be discussing the basics of successfully integrating Ortho K into your practice. This modality has been available for many years, and there are now multiple resources at your disposal. So let's begin. First question that you may have is, where do I start? Well, researching websites for training and attending conventions and lectures at those conventions for general information is really the way to begin. Now, there are two organizations that I highly recommend that you join as a member for this information. The first one is the American Academy of Orthokeratology and Myopia Control. This organization has come huge and now is worldwide, and they offer an annual meeting, and they are also affiliated with other international organizations. And that one international organization is the International Academy of Orthokeratology, and they have branches all over the world. And they also have annual meetings and conventions and include boot camps for beginners. So I highly recommend that you get involved with this organization to try to integrate into your practice. The other organization here in the US is the Gas Permeable Lens Institute. Now, they have monthly webinars that they schedule a year in advance. So you can go to their website and pick and choose which webinars pertain to orthokeratology. And they also have an archive, a full archives of previous webinars that have been presented. And just you can go there at your leisure and just pick whatever webinars you would like to listen to. And lastly, YouTube has many postings of that practitioners and organizations have posted on orthokeratology. So there's just a whole myriad of information there for you. Now, don't forget the company websites that manufacture these lenses. They have posted many information or much information about the lenses themselves, how to market it properly, and how to integrate into your practice. And also, while you're there, you can look at the material costs and their warranty information. But in any event, before you go about offering this modality to your patients, you must develop a plan. The other question that you might ask is, what tools do I need? Well, in order to adequately fit and manage these patients, you will need some type of corneal mapping device. In the upper right, you will see photographs of two Placido disc topographers, and then on the lower left, you will see photographs of a tomographer or profilometers. Now, these instruments are very different. The Placido disc topographer relies on reflections of the rings in the Placido disc to reflect off of the tear layer in order to collect the data on the cornea. The tomographer or profilometer doesn't rely on reflections of the tear layer. It actually takes a photo measurement of a large surface of the eye itself. So if you're thinking about including scleral lenses or have offered scleral lenses or other specialty type contacts into your practice, the tomographer and profilometer will measure a much larger area than the Placido disc topographers. In any event, whatever baseline maps that you're taking, they must be of high quality, because the higher the quality, the better result that you will have, and whatever type of modality that you're using for offering Ortho K patients or designing Ortho K lenses. Now, there are three different types of fitting choices for Ortho K. You can fit empirically, and it's very simple. All you need to do is send the laboratory the patient's prescription, keratometry readings, and horizontal visible iris diameter. It sounds simple, and it can be simple, with the exception of that patient must be the ideal patient in prescription topography in order for you to achieve success. Now, the other choice that you have is fitting with diagnostics or using an inventory. So basically, what you would use is you would take the patient's prescription and put it into a little calculator, and it'll tell you which trial lenses to use. So you would put these lenses on, verify the lens position, do an over refraction, and if you wish, you could dispense them. Now, there are two issues with using an inventory. In order to make it work for you, for not only one patient, but continuing patients, is that you must replace the lenses that you dispense. If you don't, you actually are degrading the inventory system. The other issue is, how do I maintain the lenses that aren't being used? In other words, how do I store them properly? Well, if you continue to store them wet, you will need to replace that solution in the vials on periodically. But if you decide to store them dry, then before the patient comes in, you're going to have to take certain lenses out of the inventory and store them wet for at least 4 hours in order for them to be halfway comfortable when you insert them in the eye. And lastly, the other choice that you have is using custom software. Now, this is what you will use to have, once you have a high quality baseline map, you will import it into the software, add the prescription and eye measurements, and this let the software create the design for you. Now, once that design has been created, you can certainly you do have options to alter the design in whatever way you want, and it's very easy to do. Now, if you're in the US, all these lens manufacturers will require passing an FDA required certification before you're able to order patient lenses. Now, let's talk a little bit about some of these providers. You should use more than one fitting technique or provider. And the reason for that is because not all patients treat similarly, and they all don't require one design. So you should, at a minimum, pick two fitting techniques when first starting to offer lenses to your patients. You and your staff should become familiar with the laboratory, their policies, and their clinical consultants. A lot of these manufacturers have some excellent marketing materials available, and the majority of them are at no charge. They offer brochures, patient brochures, waiting room stand-up cards, and they can even have some materials ready for you to help you talk to prospective patients. Now, as far as the lab consultants are concerned, these are very valuable to you for at least your first 10 patients. They will help you understand the designs, when and where you should make changes if applicable. Now, the question that is really a main is, after you've researched the manufacturers, how do I actually integrate it into the office? Well, you need to know that your patient load will change. You will have to schedule patient consultations, initial fittings, insertion and removal, and multiple follow-up visits. Now, you should have a staff meeting and talk to each member of your staff of the new policies and procedures. You should also choose one staff member as the Ortho K coordinator. Now, this could be your office manager or one of your contact lens techs, but once they're properly trained, they will take a huge load off of you, the practitioner, and make it much easier for you as far as talking to potential patients, um, making the appointment to set it up, and for follow-ups. Now, you're going to need to create an agreement for your services. The agreement spells out the associated office visits and fee structures. And you should actually have two separate agreements. One is for the first year, which has the majority of time spent. And then the second year and beyond is just a very limited visit schedule. You should also include an off-label paragraph in your service agreement because once you become more experienced with fitting Ortho K, there will be a time when you would want to fit off-label. And the other inclusion that you should make in your agreement is because there are many Ortho K wearers out there that move around. So when they move into your area and they find that you provide services for these wearers, you should have a fee structure put in place for those patients. So then you need to decide on which lens companies you wish to work with. All right, scheduling. Scheduling consultations and patients. The initial consultation should take about an hour with the parents and or the patient. Now, this time is divided between yourself and your Ortho K coordinator. What you will be doing is describing the Ortho K process, talking about the nomenclature for the lenses and the actual mechanism on how this procedure affects the epithelium. You will also offer proof sources for safety and efficacy. And here's where the AAOMC will help with having samples of these proof sources readily available for you to download or copy and give to the patients. So the second half of this consultation will be your Ortho K coordinator talking about the actual agreement and the fees. So after the patient has accepted and wants to begin, the initial workup or fittings can be scheduled and take about an hour. The dispensing and insertion and removal training is usually about another hour. Once the patient has been dispensed and they're starting their follow-up visit schedule, your follow-up visit should take no longer than 30 minutes. And once your staff is properly trained, they can manage the majority of these 4 visits. All you will need to do is probably just pop your head in after the insertion and removal process, give the patient a little pat on the back and say good job, and we'll see you soon. So let's talk about candidate selection. Who are good candidates for Ortho K? Well, of course, myopic children. And the whole study, all the studies that have been done about Ortho K being the primary modality for controlling progression. Now, other patients that are in your practice that your staff and you can actually notify our current soft lens wearers that seem to suffer from discomfort as the day goes on. These are excellent Ortho K patients, and I'm sure you have quite a few in your office. The other patients that were soft lens dropouts that come in wearing glasses, and now you have an opportunity to discuss with them this new modality that they don't have to wear any any vision correction modality during the day and only wearing the lenses at night. Okay, other excellent candidates for Ortho K are children and adults that are active and would rather not wear glasses or contact lenses during the day. Swimmers, tennis players, whatever. These patients sometimes have a difficulty with their visual modality when they're doing these activities. So these are excellent Ortho K patients. And the other good patient is prescriptions that fall within the FDA approval range. Now, the highest approval range in the US is -6. But if you're just beginning Ortho K, I would highly recommend that you stay below -4 and no more than a diopter of corneal astigmatism. These will give you excellent success rates, and this will give you good experience to extend your range once you have a few of these under your belt. All right, who are poor or not candidates for Ortho K? Well, of course, any patient that has corneal dystrophy or disease history. These are totally not candidates. So, long-term gas perm wearers, these are interesting patients because they actually fall into two categories. If the gas perm wearer has a recent prescription for glasses and can easily move from their daily wear gas perm lenses to their glasses without any visual issues, this may be a candidate for Ortho K. But the other type is that they've been wearing lenses for 20 years and they have no glasses or any other visual modality other than the gas perm lenses. The reason these are not candidates is because we have no idea what their pre-fitting corneal curvatures were. If they remove the lenses and you do a topography, they may have near spherical central cornea, but as they withdraw and don't wear their gas perm lenses for a period of time, they could end up with 2 to 3 diopters of corneal astigmatism, which actually kind of makes it even more difficult to work with Ortho K. So just be careful of these long-term gas perm wearers. They can be easy or impossible. All right, prescriptions that have corneal or refractive astigmatism only, meaning no or low, very low myopic component, plano -150 or -1/4, -175. These are not easy patients to fit with spherical base curve designs. So what you're dealing with here is you must use a custom software design that is you're able to create oval treatment zones on the back surface of that lens. Hyperopes. Hyperopes are an interesting group because you're actually doing the opposite that you do with a myopic candidate. Rather than flattening or compressing the central epithelium for myopes, what you're doing is you're increasing the central epithelium for hyperopes. Now, I will have to say that this modality is not an overnight FDA approved procedure. So it is something that you would make sure that you have enough experience with myopes before attempting a hyperope. All right, other refractions that include residual astigmatism over a diopter. These, of course, are can be corrected with front surface toric soft lenses or front surface toric gas perm lenses, but it is impossible to eliminate the residual astigmatism with Ortho K. Now, what you can do is try to design the lenses to give you spherical equivalency, meaning if you have a half diopter of residual astigmatism, you can overtreat the spherical component so that you would have a refractive result of, say, minus or plus 50, minus 50 at whatever axis. And that would probably give them the best visual acuity. All right, other poor candidates are myopic prescriptions that fall outside the FDA approval range. This means very high myopes over -6. It's not that they're impossible to do. These, of course, are off-label, but using a custom software program, it's much easier to achieve good results. All right, here is a summary of the proper follow-up schedule. First morning or within the first couple nights of wear. At the 1 week, you're looking for proper centering and treatment verification. The 1 month follow-up visit, your treatment should be almost complete, whether it's a lower or higher myope. The 3-month visit is to make sure that you're still within the warranty period. And if you need to make final adjustments, this would be the time to do that. Your 6-month schedule, you need to definitely have the patient bring the lenses with them so that you can inspect them for deposits or scratches or any type of surface issues. And then, of course, your annual visit, whereas you will provide the patient with new or fresh lenses for their next year of wear. All right, let's talk about the follow-up schedule. After your initial fitting or workup session, the lenses are ordered and you schedule the patient for dispensing. At the dispensing visit, of course, you're going to, your staff member will go through proper care and handling, along with insertion and removal training. Now, kids are sometimes easy, sometimes difficult with the INR training. You just have to continually work with them, but eventually, at some point, they will do well. And it's a very good idea to give them support from you, the doctor, coming in and patting them on the back and telling them what a great job they did. They're very proud of themselves once they're able to insert and remove lenses by themselves. And it wouldn't hurt to give them a little gift or a snack once that is achieved. Now, scheduling that first follow-up visit should be in the morning after they've worn the lens one night. Now, this also depends on your schedule. There are some practitioners that only schedule their dispensings and INRs on a Friday, and they allow the patient to wear the lenses over the weekend and see them first thing Monday morning. So again, it depends on your schedule, but you need to see them very soon after the lenses have been worn. Now, the option for the patient is they can either wear the lenses in or take them out and bring the lenses with them. Now, with the lenses on, the patient should see perfectly. So if it's a patient that is driving, they can wear the lenses in, do your evaluation, take the lenses out. But they're not the most comfortable. So they'll be very happy to, when you remove them in the morning, if they have worn them in. Now, first morning follow-up is mostly to make sure there's no corneal insult and to check to see how aligned the treatment is with topography. If the treatment is started grossly off center, then you're going to discontinue the wear and reevaluate the fit. Take photographs and video of the lenses on the eye with fluorescein if you can. Do a manual refraction without the lenses and over refract with the lenses on the eye. The amount of myopic reduction is not significant at this point, but there is truly a wow factor, meaning if it's the first time the patient is removing the lenses in the morning, their prescription will either be totally eliminated or significantly reduced. But that treatment that morning will start to fade during the day. So as the patient continues to wear the lenses overnight for successive nights, that vision will remain stable longer in the day. Now, if there's dense staining or insertion and removal issues, again, you may have to discontinue wear and reevaluate the lens cornea relationship or go over your insertion removal procedures again. Now, slight SPK during the first week or so is pretty common. So it should go away by itself. If it doesn't, then you'll need to reevaluate. But if there's no issues, the treatment is well centered, patient is seeing fairly good, continue wear for a week and then schedule another follow-up. All subsequent follow-ups after that first morning should be scheduled later in the day. This will give you an excellent idea on how the treatment is holding up as the day goes on. Now, when the patients come to your follow-up exam, it's a good idea to get them into the habit of bringing their lenses with them. Why? Well, documenting photos and videos on the eye with fluorescein gives you a very good idea how large or how small that central treatment area is, how tight or how loose the lens is, and if you're contacting the manufacturer's consultation team, they would very much like to see what you're seeing. Inspect the lenses for debris, scratches, or lens markings. So some manufacturers use the same color for both lenses, but just have different markings on the lenses if the lenses are in fact different. So there is a possibility of the patient switching lenses on their eyes, and that certainly will affect the treatment. But deposits on the lenses as the patient continues to wear for a certain period of time, if they don't clean them properly, deposits will build up on the back surface. Now, can you see these deposits? Not while they're on the eye. The only way that you can see them properly is by drying the lenses, holding them up to the light, and then viewing to see how clean the lenses are. The other thing is over refracting with the lenses on to verify the base curve corneal relationship. All right, after that first morning follow-up and everything is fine, you're going to reschedule for 1 week out. And you're going to do pretty much the same process of follow-up as you did on the first morning. You're going to take another topography, but what you're going to do here is you're going to compare the treatment correction and centration using what's called a difference map. Now, a difference map shows in the photo in the upper right, the top left topography will be your baseline map. Underneath that, you will have the current topography after 1 week, and then you're able to see how much treatment and what the refractive difference is from your difference map. And all types of topographers, profilometers, all have this ability to show the difference maps. Again, taking and documenting photos and video with fluorescein, do a manifest refraction with the lenses off and over refraction with the lenses on. Now, at the 1 week point, low myopes pretty should be fully treated. Higher myopes may take another 2 or 3 weeks to complete their treatment so that the vision stays for the majority of their waking hours. Again, at the 1 week exam, if the treatment is slightly off center, you might have to make necessary lens sag adjustments and reorder new lenses. If the patient's VA is well enough for them to get by, they can continue to wear the first lenses until new parameters arrive. But if the treatment is well centered and no modifications are necessary, then you reschedule for a 1 month exam. All right, on your 1 month exam, again, similar procedures as other follow-ups. You're going to take a difference map on your topography. And here's a little better photo of what we were talking about, a difference map. Your baseline map is at the top left. The current topography that you're taking today is underneath it. And then your resultant of the change between baseline and current topography tells you the topographical change and also the power change that's taken place. Do your manifest refraction with the lenses off, over refraction with the lenses on, photos, video with fluorescein. Now, if there's any residual myopia or astigmatism at this 1 month level, one last modification may be in order. So make those modifications, reorder new lenses. But at the 1 month exam, if the treatment is complete and your difference maps show proper centration and adequate refractive result, inspect the lenses for proper cleaning procedures. Usually at this 1 month follow-up, you might start to see some lens deposits if the patient isn't cleaning their lenses properly. But appoint the next follow-up for 3 months or prior to the warranty expiration. This is really important for you to schedule this visit after the 1 month exam to be prior to the warranty expiration. Now, the majority of companies will have a 90-day warranty. Wave has a 120-day warranty. So that gives you a little extra time to make any changes before the expiration of the warranty. It's a good idea to include a spare pair in the initial agreement. Most manufacturers will allow a generous discount if ordered within the warranty period. Now, the warranty period starts the day that you order the lenses and ends 30 or 120 days after that date. So you have to be cognizant of when this warranty expires before, and make sure that you can get that last change in, if necessary, before its expiration. So if everything is fine, one additional visit at the 6 month level, and you use the same procedures until the final or beginning year 2 annual exam. So what about the annual exam? Patients should expect their lenses to be replaced yearly, and this should be spelled out in your initial agreement. Why should they replace them annually? Well, just from wear over a period of time, the lenses could be warped or misshaped from handling. And also, deposits on the lens surface will degrade the treatment. So putting them into a fresh pair of lenses at the annual is a great idea. After evaluating the treatment, and there is some slight myopic refraction where there wasn't earlier at the 6-month level, check the overrefraction with the lenses on. If the overrefraction is now more minus, whereas at the 6-month level was plano or slightly hyperopic, you're going to need to adjust the base curve to get back to that plano or slightly hyperopic result. If the base curve is correct, there's no myopic progression, and the treatment is well centered, verified by topography, of course, then just order duplicate parameters. The follow-up schedule for year 2 and beyond is very slight, and it only involves a 6-month appointment and, again, an annual review. So, in summary, don't be discouraged if your close rate is less than expected at first. If you don't have enough proof sources or if you don't have the answers to the questions that potential patients ask, find them. Make sure that you have all your bases covered for pretty much any questions they can throw at you. Ortho K has been around for a very long time, over 30 years, but the general population is unaware that it exists and is skeptical of the procedure. The only ethnic group that is aware of Ortho K are the Asians. They know of it and have been practicing it for a very, very long time. So if you can have your first Asian patient come in and have a successful result, they will tell their friends. And from then on out, you're in good business. This is the most profitable service you can provide without insurance coverage. So a lot of times the patients will say, oh, if my vision coverage doesn't do it, how can I work with you on this? Well, most HSA plans have the ability you can use to pay for part or all of this procedure. Managing difficult patients or patients' parents will be challenging. You will have those engineers, you will have those nurses, you will have many different types of patients that have more questions than you thought could be imaginable. But yes, they are challenging, but you can work through it. And lastly, it's okay to say no. If you're just starting out and a patient that's in your waiting room with a very high prescription or has been wearing gas permeable lenses for 20 years, they take a brochure, and when you see them in your chair, they're going to hold this brochure up and say, I want these. I want to get rid of my daytime contact lenses or glasses. Well, the best thing you can do is just say, hey, be happy to accommodate you if I can, but I've just started out with this process and let me get some more experience before I decide whether or not to take you on. So it's okay to say no. And for that, I would like to thank you for your attention.